It's 6 o'clock. Just heads up, we do not have internet service here. I'm working on cell on a tablet, so I'm going to be a little bumpy on my end. But we'd like to start the meeting off. I'm Peter Rupi, Lynn's Rupi's husband. Most of you know me at this point. She's a co-leader along with Tim. I don't know if she's on. I can only see 12 people here. Essentially, we're recording this meeting, meaning that we want to capture the interaction between you all and the speaker's presentation. But be advised, we can stop this at any time for if you want to talk about something that's a little more sensitive. Your questions are very important to us. They have great value to not only the group that's here, but somebody who may get some. The Q&A can be some great information for people to watch it down the road. So feel free to raise your hand if we're in the Q&A period if you want to stop the recording process. When I get my chat feature up, I'll let you know. Then you can send me a text. And there's also I forgot what you call the little icons. You can click a raise hand button when we get to the Q&A, and I'll try to cue you into Tim or Lynn, and we'll answer the questions. So, Tim, I'll kick it back to you to introduce our speaker, and let's get going.
Okay. We have Dr. Schwalb on. He's the fellow with all the books behind him. They must cover the 11 procedures that he performs. Apologize for my weak voice, doctor. But I'm sure you had enough from me on his background with the cover note. So I'll let Dr. Schwalb take over. Are you unmuted, doctor?
Yeah, no, I'm good. You know, I think I've given talks to you guys a number of times before. I did want to think about, just sort of kind of talk to you guys about how I approach a patient when I see a patient in my clinic, and make sure I leave plenty of time for questions. And when I see a patient in clinic that gets referred to me for facial pain, yes, I do all these different procedures, but I need to figure out what exactly does the patient have. What's the source of their facial pain? So is it garden variety trigeminal neuralgia? Is it related to damage to the trigeminal nerve? The treatment, is it after shingles? Is it after a stroke? So where in the pathway from sensation from the face, going back to the nerves into the brainstem and then up to the cortex, sort of over the top of the brain where sort of all the emotional stuff and sensation exists, where's the lesion? And that really determines how to figure it out and what the best treatment is. And then, of course, to be honest with you, I see a lot of patients that come to me that really have not been tried on appropriate medication therapy, in spite of the fact that there have been clear guidelines promulgated by the American Association of Neurology and other organizations for many years. So, a lot of the diagnosis is really based on the history, and asking a patient, how their pain came on, how long they've had it, how it's progressed, what it started, has it responded to medications? Even if it's responded temporarily, that also gives me a good idea of which surgical procedure is likely to work best. And I would kind of separate it into garden variety trigeminal neuralgia on one end of the spectrum versus what's essentially phantom pain of the face on the other end of the spectrum. So with garden variety trigeminal neuralgia, usually affects people starting in their 50s or 60s, and then it's described as out of nowhere and sharp shooting, lasts a few seconds in between attacks. The person's generally pain-free. It can be brought on by touching the face. I saw a patient the other day who was describing to me that how horrible it was that she would have this terrible pain in her face, and then first reflex was to clutch her face, which would make her pain worse. But patients with that kind of classic trigeminal neuralgia have a very specific group of procedures that we do for those. And there are ways to predict, who's going to do well with what kind of procedure. Those patients tend to do well with Tegretol. A lot of neurologists are kind of reluctant to prescribe Tegretol because it's kind of a pain in the butt to monitor. You have to monitor blood counts, you have to monitor liver function. A lot of patients do develop side effects, and even to the point that they need to come off it. But it works in about 2/3 of patients, and so therefore it's worth trying. Not everyone gets side effects, so it's worth giving a shot. And if the patient responds to Tegretol even temporarily, that tends to predict, that helps with the diagnosis, that tends to predict how they're going to do with certain types of surgical procedures. Trigeminal neuralgia tends to come and go in waves. It's not uncommon for it to be seasonal. People have bad attacks and then they'll be pain-free for months or even years. And then it comes back and might be, usually if they're seeing me, it's because it's getting worse, but there are clearly patients out there who have recurrence of their cycles of attacks where it's gotten better. So patients with that kind of trigeminal neuralgia, which most of us use a classification developed by Kim Burchell at Oregon Health Science University, is described as trigeminal neuralgia type 1. Sometimes that progresses and patients have pain that's more of the time, like more than 50% of the time. And usually the characterization of the pain changes. Instead of short, brief, electric-like attacks, it's more boring, underneath the skin, throbbing, aching, sometimes even burning. And that's TN2. And those patients, aren't going to do great with medication. They're also not going to do as well with surgery. So in terms of, patients I see, the first question is, we have them fill out a questionnaire that's similar to the questionnaire that Kim Burchell has on the website at OHSU, which is basically, if you think like Kim does, this is how we think about your diagnosis. This kind of tells us what you probably have and how we approach it, and also tells us kind of, what treatments you've had and that have failed. So that's really helpful. And especially, knowing whether the appropriate medications have failed. Patient who comes to me with classic trigeminal neuralgia, who's never been tried on Tegretol, they need to go try Tegretol. I'm not necessarily going to be the one who's going to manage that. I'm going to generally send them back to their neurologist and say, you're really not a candidate for surgery until you try Tegretol. And then the question is, okay, so let's say they have TN1 or TN2. And they failed medical therapy. We're pretty sure of the diagnosis. What are the options at that point? And let me see if I can pull this up. Oh, I'm unable to screen share. Can you let me screen share?
Oh, sure. I sure can. Absolutely. There you go. Sorry about that.
Great. So you should be able to see my screen. I can only see a few of you now.
Yeah,
but that's
yes.
okay. So, the surgical options are the traditional microvascular decompression, which is also called MVD. This is brain surgery, also called the Janetta procedure after Peter Janetta, who really popularized this in the 80s and 90s. And with that procedure, essentially what you're doing is, and you can often see this on a preoperative MRI, and I can tell you the patients that do best with MVD are the ones that have responded to Tegretol at least transiently. And when you get a very specialized MRI, and it's not like your garden variety MRI, you can see a blood vessel pressing on the nerve and distorting its course. Those patients are going to do great with kind of the best results in terms of long-term benefit. They're not going to get numbness from the operation. All the other procedures that we do for TN1 or TN2, the general idea is you are slapping the nerve around. You're trying to give the patient some degree of numbness so that they don't have pain, but not so much numbness that they have essentially phantom pain of their face, so that they have what's called deafferentation pain. Does everyone know what phantom pain is?
No, I don't.
Okay, good. So I'm glad I asked. So phantom pain, we see this, this is the brain does not like it when it does not get its normal inputs. So, we've known about this for millennia. People who in wartime suffer an amputation, they lose an arm, they lose a leg, and they feel pain in the limb that's no longer there. Right. And so we see this after amputations, and we see this after severe nerve damage. So if you have severe nerve damage, yeah, your face may still be there, but if you have no sensation or really reduced sensation, that can be painful because your brain isn't getting the input it wants. And so that's really phantom pain. And some of the treatments can be psychological or mirror therapy, and medication, and sometimes they're surgical. So we're always concerned, and probably the complication that we're most worried about in these ablation-like procedures like glycerol balloon, radiofrequency, gamma knife, or stereotactic radiosurgery is we're worried that we're going to cause too much numbness and that can be painful. It's hard to treat. And many patients describe it as actually worse than their initial pain, or tearing out the nerve. We sometimes do that. If the person has pain in their forehead, and inject alcohol, and that'll usually take care of the pain in that nerve for a year or so. So all these procedures are ablative, and a lot of it is, other than MVD, a lot of it is kind of figuring out, how long does the person need benefit. How long does the person need benefit? What's their general health like? How scared are they of complications? But generally, if I see a healthy 40-year-old with straightforward garden variety trigeminal neuralgia, I'm going to do a microvascular decompression. The results are really quite good. Patients at 15 years still with 80% pain-free off all medications, and you can do this with this is a patient of mine. It's basically a 1-inch bone flap behind the ear to get enough access to be able to move this blood vessel away from the nerve and put a piece of Teflon to keep it from slipping back. And that can be, super, super effective in the right person. Am I going to take an 85-year-old, and put them through a big brain surgery if they have heart failure, are on blood thinners, diabetic, 8 other medical problems? No, it's generally not a good idea. They might not need 10, 15 years of relief, if they're already 85. When I'm talking to patients in their 70s, we try and guess what their life expectancy was. I saw a patient on Monday who I think was 76, and offered her this procedure. And so, you can definitely do it for patients in their 70s. In some ways, it's easier to do in patients in their 70s. There's a little more room. There's a little bit of atrophy that actually makes the surgery a little easier. And frankly, they tend to tolerate it quite well. But I think in general, you don't want to use a hammer for a screw. Try and figure out what the best treatment is for the specific patient. So the other procedures, as I discussed, they go from kind of minimally invasive to more invasive and involve beating up the nerve a little bit to get a little bit of numbness. One is focused beam radiation. And so this would be, we've been doing this for over 50 years now. It can take time. It's there's no incision, but you do have to lay still. At Henry Ford, we actually don't put the name on the person's head. We use a mask that holds the person's head from moving so that you can focus 100 different beams of radiation just on that nerve, so you're not damaging the rest of the adjacent brain. It often takes a week or two to kick in, and the earlier the response is, the more likely it is to help. There is definitely a branding issue. People hear gamma knife, gamma knife, gamma knife, gamma knife. There's a really difference between the different modalities, whether it's gamma knife or, if you can mute yourself, Peter.
I'm working on it. I am so sorry.
One of your devices is not muted.
I'm well aware of
the camera. There you go. So there are linear accelerators. There's CyberKnife. We actually have a really great group of radiation oncologists that have a lot of experience doing this. But to be honest, from a radiation oncology point of view, developing with their physicists, developing the plans, and we do this together, to hit a 4 millimeter target. This is easier than most of the other things they do in terms of brain tumors and things like that. There's the way that they were actually doing this initially and targeting. Remember when Lexell started doing this, this was before we had MRIs. So what they would do is put a needle through the face and inject this tantalum, which is like a powdered metal, so that then they could target it with CAT scan. And they found that when they were doing this injection, and this is kind of what the injection trajectory looks like, back, we've been doing this since like 1912, so over 100 years. When you injected the tantalum, to get it to stay there, it was dissolved in glycerol. And it was noticed that a lot of these patients, just from doing that injection, their pain went away, and you didn't actually have to go and do the radiosurgery. So that's how we came up with glycerol rhizotomy. And this is what it looks like. For glycerol, we sedate the patient. We bring them in the operating room. I usually leave them on the gurney. We put a needle in at the side of the face. I have another finger in the mouth just to make sure I don't go into the mouth cavity and have to worry about infection. And generally, when I get in the right place, the patient bites down a little bit because this nerve also is involved with chewing. And then I can inject a little dye, make sure I'm in the right place, and then sit the patient up, inject the glycerol, and it's denser than spinal fluid, so it just kind of sits there, and you just have them sit there for a couple hours, and that can be pretty effective. Other techniques involve putting a needle in and heating it up and burning the nerve. This is nice because you can get feedback, so you make the patient numb enough to get pain relief but not too numb. You can titrate how much you're burning the nerve, and the flip side of that is you also do need a fairly cooperative patient, although there are some groups around the US that are doing this with patients fairly asleep at this point. And you can target the different divisions, so you can target whether the patient has pain here or in the jaw or in the forehead. In my shop, we are able to place this under X-ray guidance, as well as putting little optical displays on the needle and on the patient's scalp, so that you can kind of register it to a CT and get it in the right position and aim right for where that nerve comes out at the base of the skull. So this is what that looks like, and I can try and blow that up. And this is the trajectory we put it down. There's also another procedure that we do under general anesthesia that for, one of the concerns when you're beating up a nerve and making it numb is you don't want to cause numbness of the eyeball, because then if you get stuff in your eye, you don't notice it and you don't blink it away. And so, we definitely worry about, for a patient who has involvement of their eye, this is, if we're not going to do MVD, this is really the procedure of choice because it tends to spare those fibers that go to the cornea. So I tend to favor it for that. It's also great if the person just is not going to be able to tolerate awake surgery. The patient's completely asleep for this. And I actually seem to be doing more and more of these recently. And the patient's completely asleep, they go home same day. Procedure takes about half an hour. Radio frequency, because you're waking up the patient, putting them back to sleep, takes about an hour and a half. Glycerol takes about half an hour, 45 minutes, something like that. So this is pretty straightforward. Occasionally, just from the shape of where the nerve sits at the skull base, you can't get a good inflation of the balloon. It's just a vagary of the anatomy, and it doesn't work very well. But most, 90-95% of the time, balloon works quite well. I saw a patient on Monday with multiple sclerosis related trigeminal neuralgia type pain that was intermittent, and he's coming down on his meds, said he should have done this procedure 2 years earlier rather than suffering, and did great with some numbness. You can cut the nerves in the face before they go into the skull, and those nerves will regenerate in a year or two, and I've definitely done this for some patients. It can be effective. So, in terms, not compared to microvascular decompression, but this review, even though it's about, 18 years old, is still pretty accurate. The radio frequency is the X's, patients do very well right after surgery, but once you're getting 5 years out, it's not quite as effective. You can repeat these procedures, but they often wear off. This is glycerol, which is pretty similar to radio frequency. As you can see, the focus beam radiation, only about 65 to 70% of patients are pain-free, which is still great. It's better than a lot of other operations we do, but it's not as good as the other techniques. And then in terms of long-term results of things like microvascular decompression versus balloon versus radio frequency, looking at 20 years, MVD is still like 80% effective. So patients, at the beginning, it's pretty close to 100. You tend to lose about 4% each year or so over time. So that's really effective. In terms of complications, mortality is essentially nil or pretty close to it. The big thing I worry about with microvascular decompression is you're around the nerves for hearing. So there is a risk of some hearing loss that's anywhere between 0 and 20%. I think it's probably about 5 or 10%. It's not uncommon for patients to tell me that they've lost a little bit of hearing in that year. So I usually get an audiogram before surgery to make sure their hearing in the other ear is good. And then, as you can see, the risk of decreased sensation with MVD is quite low. With these other procedures, it tends to be all over the place as to whether they get some decreased sensation. And the thing that we worry most about is anesthesia dolorosa, which is that painful numbness. With balloon, everyone gets a little bit of weakness in their chewing on that side. And, most people are fine with that. It can also, if you have a history of cold sores, it can reactivate the herpes virus, and it's not uncommon for patients to get a pretty bad herpes attack after any of these procedures because you're messing around with the nerve where this virus lives. But, the thing we worry most about, and as I said, patients with anesthesia dolorosa, where there's phantom pain of the face, medications really don't work. And any of these procedures is completely inappropriate. You will make the patient worse. And so you really need to take a different approach. Generally, there are a number of different ways to do this. We can put electrodes underneath the skin if it's very localized. Obviously, if the pain's in the eyeball or in the inside of the mouth, that's not going to be effective. But if the pain's on the surface, this can be really effective. And we have newer devices that actually do quite well, even though they're not a lot in the literature. We've been doing some other techniques for patients with this kind of neuropathic phantom pain in the face, where we can put stimulators at different points in the circuitry of the brain, either at the spinal cord, although it tends to cover the outside. It's hard to get coverage around the nose and mouth, and that can be helpful. Other options include putting electrodes in the brain, putting electrodes on the surface of the brain, like motor cortex stim, and I've actually done like 2 in the past 3 months, which is more than I've done like the past 3 years, and that can be really helpful. I don't have a lot of experience with putting drugs up near the upper spinal cord, where the neurons that are important in facial sensation live. But my colleagues in Cleveland do, as a technique that we're used to doing. So instead of taking an oral medication that might have a bunch of side effects, we can deliver medication right there. And that can be quite helpful. And then I don't do these procedures yet, although I probably would, if I find the right patient, I would definitely consider it with some proctoring in terms of doing basically burning the nerve in the spinal cord, upper spinal cord, or at the base of the brain to interrupt the circuits. So this is an option as well. So we have lots of options, so for a patient who doesn't have garden variety trigeminal neuralgia and has what's called a more neuropathic type pain syndrome, it's really going to depend on the cause and the location. If it's post-stroke, especially if it's the outer face, I'm going to do a high cervical spinal cord stimulation as a trial. So, you do it. If it works, that's great. If not, the patient doesn't have a permanent implant or anything like that. As long as they have some sensation in the face, there's always an option for putting electrodes underneath the face. I had a patient I operated on that I just saw in clinic on Monday. She had post-shingles like pain in her forehead. And there's a new device that I just tunneled underneath her skin, and we snaked a receiver behind her ear. There's no battery pack or pacemaker. And she's got a little transducer that she attaches to her glasses. And that beams energy, sort of the same way as putting your cell phone on a mat and charging it that way. She's got a little pad on her eyeglass, and that transmits energy to the electrode, and she was actually completely pain-free. And she was completely miserable before surgery. And then if all else fails, then we start talking about post-herpetic is after shingles, that's the medical term. And spinal cord stimulation or peripheral nerve stimulation. Then if all else fails, we've got these other options, including deep brain stimulation, tractotomy, nucleus caudalis DRES, or motor cortex stim. So that takes us to about half an hour. I am happy to answer any questions. And, I'll leave my slides up in case that helps with answering any of the questions.
So I'm back online, so I can see all of you. And if again, we're recording this. If anybody wants to stop it for any reason, let us know. You can raise your hand, or you could just speak up with a question, or else you can use that little icon and put a reaction up, or send me a chat. That's up as well. Any questions for the doctor? Alan?
Yeah, is there any fear of a person with TN like myself that's in remission with getting a Shingrix vaccination for shingles?
No.
Okay, good. Thank you.
Yeah.
Doctor, you've got a question from Teresa. Why does TN come back despite surgery?
Oh, I wish I knew. So sometimes, yeah, I mean, there are a couple of issues. Sometimes it depends on the type of surgery. So, if you're talking about after microvascular decompression, sometime the Teflon slips or another vessel becomes tortuous over time as we get older and comes into contact with the nerve. And so if I see a patient, who I've done an MVD on, and their pain comes back and it's the same pain that they had before, the quality is the same, it's not burning or anything like that, I'll generally re-image them, and actually reoperation has a similar success rate, and it's generally worth doing that. For the other procedures where you're talking about, slapping the nerve around and trying to give a little numbness, the nerve regenerates. And so, it's a patient on Monday who I did a balloon on, and, he said that it was really numb. It was actually because it was a balloon. He was having trouble chewing because he was worried about chewing on his tongue. But even so, even after 6 weeks, the area of numbness was getting smaller. So, in patients that you're doing ablation on, if it is a vessel that's causing the problem, the vessel's still there. There are patients with facial pain that don't have blood vessels pressing on the nerve that we don't really understand, why they have that pain. And so, as the nerves regenerate, they can have recurrence of their pain. In general, with the ablative procedures, it's that really delicate balance, because if I don't make them numb enough, their pain will come back faster, but I don't want to make them too numb that it's bothersome or painful.
So there's a
And
question.
if I'm not answering your question the way you intended to ask it, let me know.
Teresa, did that answer your question? Not hearing Teresa. Oh, you're muted, Teresa. There you go.
I put it in the chat. Yes. Thank you. That did answer my question.
Okay, great.
The next question is from Katie. So if the vessel is not distorting the nerve in the MRI, is it unsuitable for an MVD?
That is a very controversial question. So some people would say no. I think it depends on how much you trust your MRI. I think if I don't see a blood vessel there, it's less likely to be as helpful. In those cases, it may be more appropriate to do one of the ablative techniques. Every one of us is, neurosurgeons are trained. If you go in there and there's no blood vessel, you kind of open up the nerve and separate the fibers, and that usually gives pain relief as well. So there's always kind of a backup plan. But what I would say is, Dr. Burchell would say it's probably not worth doing an MVD if you don't see a blood vessel there. I'm a little less confident in my imaging to say that there's definitely not a vessel there.
Could it be underneath the nerve, doctor?
I mean, we're looking at it in 3 different planes, so we should be able to see a blood vessel pressing on the nerve.
I can't tell if I'm muted or not.
You are not.
I'm not? Okay, so this question was initially from me. So my MRI does show a vessel pressing on the nerve, but it doesn't say, it says that it is not distorting the nerve.
Yeah. I mean, in that case, I would say your chances of being the chances of being pain-free seem to be really related to is there a blood vessel there? Is it distorting the nerve? How much? And also, did the person respond at least temporarily to Tegretol? So, if you had really garden variety, straightforward trigeminal neuralgia type 1 with a vessel touching the nerve and responded to Tegretol, you're reasonably young and healthy, I would still advocate an MVD.
That's helpful. Thank you.
And Tegretol has helped, right, Katie?
Yes, it has.
Yeah.
Mhm. Thank you.
Yeah, no worries.
There was a question from Maria. How do you feel about repeat MVDs? What does it take for you to consider it?
I mean, I think I want to see that. I'll get an MRI. The real issue is the pain the same as what prompted the initial surgery? It's also like, how long did the person get relief? So usually it's based on the character of the pain and repeat imaging. If I get repeat imaging and there's a ton of scarring and I'm worried about damaging the nerve, I might not advocate for a repeat MVD. Again, it's also going to depend upon the age and general health of the patient.
Maria, we hope you answered the question. That's questions answered for you. Moving on to Tuan, what are the chances of Teflon for MVD procedure getting rejected by the body?
I've definitely seen patients where they develop a fair amount of scarring around it, but I don't think, Teflon is pretty inert. We don't really see like a raging immune reaction against it. It just doesn't happen. So I'm not particularly worried about that.
To that note, I had an MVD where the Teflon wasn't rejected from my body, but the bone plate that they used was
the titanium.
No, it wasn't titanium. It was something else. I mean, forgive me, I don't know the product, but it wasn't the titanium, because I have that on the other side, fine. But the one on this side, they had to take it out because it was causing all kinds of irritation. And they thought at first it was maybe a little infection, but I did not present with an infection. So they replaced it with some sort of mesh, something
like a titanium mesh.
Something, yeah.
How long ago was the MVD, Maria?
Oh, that was 2015. That second one, yeah.
Yeah.
Maria, why don't you follow up with your second question about the veins?
Oh, I was wondering if you're talking about an MRI, and then people refer to like a specialty MRI that shows arteries pressing on nerves, and would the veins present in the same way on the MRI?
Yeah, it often looks a little bit different, but it can be hard to tell. A lot of times we also get an MRA, which is an MR angiogram, to see, try and help differentiate that. But, I don't know that it would change my surgical management. The patients that tend to have venous compression from veins tend to be the patients that present younger. So, like I talked to a patient today who's like 31, and, has an abnormal blood vessel that I suspect is probably a vein, but it's really distorting her nerve. And those patients can still do, very well with MVD.
Follow-up question from Tuan. Do you put the skull bone back after the surgery?
I do. Yeah. Yeah, I think most of us do at this point.
Lynn from New Zealand asks, do you know if there is anything new in surgery on the horizon, but not yet passed?
Not that I know of. I mean, I think that, actually there is this group. I edited a video issue of a journal the past year or so for pain kind of along the jaw, in the jawline, and involving the teeth, where this group was putting stimulators kind of underneath the skin, but like from the inside of the mouth. So that's pretty new. But that's such a specific subpopulation. I should also say, like, any of these stimulators, like, they do not work for classic trigeminal neuralgia. In fact, they probably make it worse. So it's really only for patients with some degree of nerve damage that we consider putting stimulators in.
What about new meds, doctor? We had questions about whether any new meds on the horizon.
No, I mean, the history of medications is really happenstance, right? Like I don't think there's a single, I mean, Tegretol's been around so long, that wasn't even an issue, but like no one's going to the FDA for trigeminal neuralgia as an indication for any medication, right? It's just too rare a condition for a drug company to run a drug development trial. Drug development trials tend to take about 5 to 10 years and about $10 million. So unless the industry sees a potential return, they're not going to do it. Most of the medications that we use, they're all stuff that was approved for other conditions, and now there seems to be good evidence that it's helpful for facial pain. That's true of all the anti-seizure medications, neuroleptics like the calcium channel medications like gabapentin, GABA and agonists like baclofen. They're all stuff that, drugs that were developed for other reasons and have been found to be helpful for facial pain.
So you haven't bumped into any new ones by chance again?
No, not that we've seen. And, occasionally you see a report of, patients who failed most other stuff, and then they try, something else, and it's anecdotal, but we don't see a lot of trials of, new medications. And frankly, it's hard to beat Tegretol.
Right.
Melody has a question for you, Doctor. Go ahead.
Hi. Thank you, Pete. Yes, for TN2, you mentioned that that was not very good didn't work as well surgery wise. For possible dental procedure damage done, creating the TN2, what would you recommend, or what would you think as far as the slapping the nerve around all those different procedures? Or I wanted to ask you also about the PNS.
Yeah. So, yeah. TN2 is not caused by any oral surgery, kind of by definition. No. So it's basically what you need to sort out, or what I need to sort out as a surgeon is, did the patient, we see lots of patients that have facial pain, and it's sort of, dentist sees them and says, oh, you got a bad tooth, let's take it out, and that just doesn't do anything. That's a problem where the problem wasn't diagnosed accurately. Then there are the patients who, have a dental procedure and develop new pain from nerve damage. That's a different problem. That is not trigeminal neuralgia. That's a deafferentation pain syndrome. It's not necessarily, so there are degrees of phantom pain. You don't have to have complete damage and complete lack of sensation. Even some damage can cause a painful syndrome. Those are patients.
So what do you do for the
if you already have numbness in that distribution, any of those ablative procedures or MVD is not appropriate. In fact, it might make your pain worse. And those are patients that we talk about stimulation, at least ablation.
So,
if we're talking about ablation at the brainstem, like a DRES or trigeminal tractotomy, that's a reasonable thing to consider. But usually we consider stimulation first.
Yeah, the PNS, right?
Yeah.
Yeah. And how would the PNS exactly work?
It's
complicated.
Yeah, I mean, I think I'd be on my way to pick up my Nobel Prize if I completely understood that one too. I mean, a lot of it
do you
has
do
been,
a lot of those?
We do. Yeah,
Okay.
I mean, I think there are a couple ways of thinking of it. One is that it kind of decreases abnormal activity in the brain by giving the brain some input that it likes. But it also is probably is a lot more complex than that in terms of preventing. One of the problems is that you have something called allodynia, where just a gentle touch, results in painful sensation, and so it prevents, stimulus from being perceived as painful when it shouldn't be. So it's a little more complex than that.
Donnie knows many of us have used opiates for the dental type problem. You call it differentiate pain. Can't ever say that word. And we refer to it as TN2. Maybe.
No, it is not TN2.
Yeah.
It is not TN2.
I understand that. But
so that is not the classification. So don't refer to it as TN2. Let me pull up the classification again.
Differentiate pain. I can
pain?
It's in Birchel's classification, which I do have. I mean, I'm pretty close to Kim, but I do have problems with this classification. So that is either trigeminal neuropathic pain or trigeminal deafferentation pain. That is not TN2.
Right, but you still use the term trigeminal. So we use that.
No, I do not. I do not.
I thought you just.
It is not trigeminal neuralgia. Not if it's from damage to a nerve.
Right.
It is facial pain, but it is not trigeminal neuralgia. Trigeminal neuralgia is very specific to either TN1 or TN2.
Right.
How do you know if it was damage to the nerve? If it occurred after
generally
all,
there's no work. Yeah, I mean, it's based on the history. It's also based on the exam. I mean, I've seen.
Right.
I did see one patient this past year who didn't have MS, who had what seemed like garden variety trigeminal neuralgia that had a little bit of numbness, but that's rare. In general, the sensation when I test with a pin or when I test with a little bit of gauze touching the person's eyeball, the sensation's normal.
Right. Okay, so if you have deafferentation pain, from injury, I guess. Let's just say you've diagnosed it that way. You would go straight to a PNS, right?
Yeah, it depends where it is. I mean, I'm not going to get good coverage if it's like on the inside of your mouth or on your eyeball.
It is on the inside of the mouth.
Yeah, so that's a little bit harder. So, then I would either send you to New Jersey or, where they've been pioneering this technique, or talk about like spinal cord stimulation.
Where would you? New Jersey?
Yeah, I forget where these guys were.
Surgeons of New Jersey, because I've seen them online.
Let me see. Let me see if I can.
What about Dr. Brown in New York?
No, I mean, I don't think Jeff does that kind of stuff.
Okay.
We've had hundreds that have found opiates, as you know, Dr. Schwalb.
Yeah.
Not that would be in your bailiwick, but we've had hundreds that work for opiates of various amounts and types have worked for that type pain.
Myself, it's pretty hard to get these days.
Well, we still are. We've got some angels out there.
Well, that's good.
I've been on it 25 years, and CDC is going to resurrect their guidance of 2000.
I know. I'm actually supposed to comment on that.
If I can help you, I'd love to.
Yeah. No, I mean, yeah. So I'm trying to see where this. I don't know.
Sorry to ask-
I'll see if
sorry
I
to
can
take-
find that.
Sorry to take so much time on this. It's just my TN.
No,
Well,
it's very important.
I used to call it TN2, but we won't call it that. We'll call it the
Ah, here we
DF
go.
pain. Mine's suddenly taken on a little turn for the worse. So the opioids were working and the gabapentin, but now things have gotten worse, and so I'm looking into other possibilities.
Yeah. So this was the article. Let me see where these guys are.
You need to see the new pain.
Yeah, so it's these guys at St. Barnabas in Livingston, New Jersey. It's this guy, Pascover, Boris Pascover. So you might want to reach out to him
Who
if
is
it's
it?
involving the inside your mouth.
Oh, Boris. Okay.
Pascover, P-A-S-K-H-O-V-E-R.
Okay, I see that. Yeah. Okay.
Yeah, so they're doing stimulation like in the mouth.
Okay. Okay, great.
So I don't have any experience with that. So
Okay. Thank you.
yeah.
So Twan wanted to know about pre-surgery preparation. I'm guessing he meant like with the MVD where you drill a hole in the skull, and what's involved right before the surgery, the actual surgery part of the MVD. And Twan, fill in the gap if I missed something.
Yeah, I'm not sure what you mean.
Yeah.
Here he is.
Can you hear me?
Yeah.
Yes.
Yeah. What I meant is, like before the surgery, you have some prep work, right? Some UFM, they have a different technique, different kind of monitor. And some other doctor and John Hopkins, they do different things. So like a prep work, they taking data and the data point being used during the surgery. So what?
Okay. I mean, what we do. Yeah, I mean, what we do is I tend to use image guidance so I can do a very small opening. I tend to get an audiogram prior to surgery for counseling, and then kind of normal pre-op, workup, labs, make sure the person's healthy enough to undergo an operation. During surgery, I monitor hearing. So there are ways of putting a small microphone, a small speaker in the ear, and then recording the brain waves as the signals go from the eardrum up to the brain, so you can see if there's any problem, and also looking at sensory fibers coming from the arm up to the brain to make sure that nothing's being damaged while we're operating, or we're not pushing on stuff too much to expose the area. So that's pretty standard. The image guidance to make a smaller opening, not everyone does. I tend to do that, but is that what you mean?
Yeah.
Yeah.
And then some surgeon instead of cut a small piece out in the back of your ear and they put it back in. Some at John Hopkins, what they do, they drill a hole in there, and when they get done, they kind of seal with some kind of filler.
No, I mean, for us, it's a bit of a mix. So I usually put the bone back and then put a little bit of bone putty, so the skull will grow back in faster. And I think that's what most of us have done. My partner, Dr. Malik, published on that a few years ago. So we don't leave it open, because if the muscles back here stick to the membranes that cover the brain, it can cause headaches. So I think at this point, almost every neurosurgeon is going to put something in there to separate the muscles back here from the dural membranes that cover the brain.
Yeah, at John Hopkins, it was explained to me that when they drill a small hole, I guess small enough that they can put some kind of fillers in there, more like a.
Yeah, they've got at Hopkins. Yeah, I know those guys pretty well. They've got this huge effort that they've started. They founded a company and they're doing these like custom plastic implants, and they're working with a plastic surgeon that has an appointment in their department. I think that probably makes sense for patients with aneurysms or brain tumors, where you want to be able to monitor things with ultrasound more easily after surgery. That's not really relevant for MVD. But they've got a company, so they're pretty interested in doing stuff related to that.
Yeah, because Dr. Judy Huang was the one I talked about. And more like a cement type of thing, and she said that after I don't know so many minutes, and it's really hard, like bone. But
so it's probably methyl methacrylate. Yeah, we did that. Yeah, I haven't really done that. We tend to use the your own bone. I think that probably works a little bit better. And then some bone putty.
Okay, thank you.
Yeah.
So Dr. Roseanne would like to know, how quickly can a nerve regenerate?
It depends. So sometimes it won't. I think it's in general, we tell people, I also do like a fair amount of peripheral nerve surgery. In general, we tell patients that at least motor nerves regenerate about 1 millimeter a day. So it tends to take months. For the ablation treatments that we do, sometimes they never do, completely. A lot of patients have some residual degree of numbness forever, especially if you really damage the nerve. So it's pretty variable. It's generally in weeks and months. It's not in days, it's not in years. So usually people have pretty stable, if they have a little bit of numbness, it's pretty stable by the time you're a few months out. It's usually bigger right after the procedure, and then the area or degree of numbness gets less over time. But it tends to be pretty stable once you're about 6 to 12 months out.
I asked that only because it's Roseanne. My husband had pain 3 weeks after his MVD, full pain. And then an MRI was taken by another surgeon just in February. And there's another compression point now under the trigeminal nerve. So I didn't know if that new compression could be just the nerve regenerating, or something went awry in the first MVD, or...
Yeah, either they missed a vessel or the Teflon slipped or something like that, or the vessel slipped back into place, would be my guess, based on that time course. And someone asked before about like taking patients back to the OR. A patient like that, I would take back to the OR pretty quickly.
Glad you got an answer, Roseanne. That was with Dr. Brown, right? You're muted.
You're muted, Roseanne.
Sorry. The first surgery was not with Dr. Brown. It was, I said, in Manhattan, in Cornell.
No, he found the second one.
But my husband just had a balloon compression on Monday with Dr.
Yeah, with Dr. Brown. Yeah, he's the king of balloons.
Yeah.
How did he do, Roseanne?
The first week was a little touchy. He had twinges and then some shocks, and then full-blown pain by the end of the week. And then after that surge of pain, now we're 4 days out of no pain. So right now,
that's great.
Monday, but we were pretty nervous. He hasn't weaned off any medicine yet. He's too nervous, but he's right now 4. Is that common for balloon, that he can still have some?
Yeah, it's common. It's common with all the ablative procedures that, RF, balloon, glycerol, that, there are definitely times where, as soon as you're done with the procedure, the patient's pain-free. There are definitely cases where person still has twinges, or, seems to kick things into action, and takes a while for things to calm down. So yeah, so I mean, I tell patients, when we're doing balloon or RF, like, don't freak out if you're not pain free after the surgery. We'll give it a little bit of time and see how things calm down before we call this procedure a failure.
Well, I'm really glad you were able to present so many procedures, Dr. Schwalb. I didn't realize how many you did. That's fabulous. We are so glad to have another great neurosurgeon nearby.
Amen.
Oh, my pleasure. Yeah, I just try and tailor. It's good to have a busy, a crowded toolbox. So
Yes,
you can really tailor it to the right
absolutely.
patient.
Absolutely.
Yeah.
Well, we thank you so much.
Yes, thank you.
My pleasure.
More questions, Pete?
There are more questions, Doctor. Do you have time, or do you got to scoot?
I'm getting my family looks ready for dinner, but I can answer one or two.
Okay. No, well, we'll just do the last one then. Thank you so much. Teresa wants to know, what thoughts do you have about TN getting worse immediately after MVD, like new triggers, pain shocks, and multiple branches, as opposed to one?
That's pretty unusual. I mean, I guess it can happen from manipulation of the nerve. I can't say that I've seen that in my practice where you get spreading to another nerve. But I would, I guess there are two things. One would be, I know there are definitely some surgeons, including one of my partners, who really tapers medications very quickly after any procedure. I tend to wait a little bit so that kind of stuff doesn't happen. So it could be tapering the medications too quickly. It could also be just from irritating the nerve from the procedure.
Hi, this is Teresa. So this is actually what happened to me after my MVD, which is like kind of why I'm just maybe trying to get your take on it. So I guess I was just curious if you had any thoughts on it. My surgeon was great. He was just like, I don't know why this would have happened. He kind of said the same thing that you did, is that maybe the nerve was irritated by the procedure.
Yeah.
And then we did taper my meds like really quick. So that makes a lot of sense. I did end up having a rhizotomy pretty much like immediately after, because we wanted to like recheck it and make sure everything was okay. And I've been doing fine from that. But I was just curious maybe if you'd ever experienced that and maybe what your thoughts were. So thank you.
Yeah, no worries.
Fantastic.
Who was that talking?
Teresa Perlman.
Oh, Teresa.
Yeah, we can continue on. We just want to be respectful of Dr. Schwalb's time and your family's support. We appreciate you so much, Dr. Schwalb.
Okay, nice
thank
to see
you,
you all.
Doctor. Thank you so much.
Thank you.
Take care.
Okay,
Good night.
take care.
We can still continue on, you guys. It's just they have long days as surgeons, and we appreciate them. We don't want to burn them on anymore.
No.
Yeah, I got a busy day in the OR tomorrow.
Take care.
Okay, thank you.
Did anybody have more questions? I'll pass them on to Dr. Schwalb separately. Send them to me and I'll send them on.
I don't know how we get them back to people without any emails. Lynn, do you want to read the questions, starting with Katie?
I think, honey, I think we're good.
What I'm talking about is they can email them to tagdude@webtv.net, and I'll get them to Schwalb and get an answer for you.
I can do that, Tim.
No, that's all right, Pete. I'll handle it. Thank you.
Hey, Lynn, I got a quick question. This is pretty simple, I think, for you. He had down of the lingual nerve. Do you know what the lingual nerve is?
Yep, it's towards the tongue side.
Oh, meaning back farther, or
is yours Max? Is yours on the top or the bottom?
Mine is on the top, and it's like a whole gum area where they took out teeth. The very back, a couple of teeth.
Okay, yeah, it would be towards the inside of your mouth where your tongue is.
Okay, so I guess that would be the area, right?
That you're having the problem with? Yeah. You can have the lingual side of the upper as well as the lower.
That would be considered lingual. Okay.
Mm-hmm. Yeah.
That's what I was just wondering. Okay, thanks.
Yeah. And I think when Dr. Schwalb was talking about the numbness, like after an MVD, it may take a little while to get back, but he wasn't talking about the ablation, because typically ablations last 6 months to 2 years, somewhere in there. Like even what Mary Ellen has. I don't know if Mary Ellen, are you still on? Yeah. How long is your rhizotomy supposed to last?
He said months to years. He couldn't give me an answer.
Yeah. So, but yeah. So I'm saying the ablation, those types of procedures that they will last longer with the numbers, which is what you want, right? Yeah.
God willing.
Yep.
I
don't know what to pray for anymore. There's so many things going on.
Too much, right?
Mm-hmm. Too much. Yeah, absolutely. I'm glad your husband gets the procedure done, Roseanne.
We were bad last week, boy. We were a mess.
Really glad to hear that. Really glad to hear he's doing good.
Thank you. He was so depressed, and I have to say, if anybody visits Dr. Brown, it just goes to show you, like, a surgeon. The first surgeon we lost so much faith in right away.
Yeah.
He said all the right things going in for the MVD, but going out.
Yeah.
Dr. Brown called us on his cell phone. He met us at the hospital. He is. But I the millions of questions you have and the fears, it's just overwhelming.
Yeah.
I was thinking with Mary Ellen, I had asked the surgeon, when your surgeon, how do you know when do you go for a balloon compression and when do you go for the rhizotomy you had? And he said he didn't do balloon compression. So he wasn't able to answer us. When I asked Dr. Brown, he goes, well, I do balloon compressions. And then Dr. Schwalb just said he's, famous for that.
Yeah.
So, we, it's like every step, you don't know is this the right step or not? Like, that's what we were facing. And I'm sure that's for everybody. What step do you take? Are you doing the right thing? You're not doing the right thing?
And then we change, like, every 10 years, our DNA is, I mean, everything is changing where, our organs are working differently. Everything's changing. So, yeah.
But Dr. Brown, he said to him, my husband, because he has another compression under the trigeminal. And I said, well, does that from the first MVD, could it have been? And he wasn't exactly saying, but he was saying that he probably missed it, but he didn't say those words at all. He said in a very eloquent way.
Yeah, but that's why you can tell he would go right back in, and that's what I said to you.
Because if the MRI showed it complicit, like it was so evident. Yeah. And then we were in the hospital. My husband had to go for a Dilantin infusion because he was 5 months, 24/7 pain.
Oh my gosh.
Dr. Brown says, come to the hospital now and I'll get you, we'll start a Dilantin infusion. And he told him, you need another MVD. But he saw how my husband, it would have been his 9th surgery because he did fall. He did fall and he saw my husband's stress and he goes, all right, we'll just do the balloon compression. So he, I believe, did that just to get him out of immediate pain because he was so depressed from it.
Oh, that's terrible.
Right now we're 4 days.
4
days. It's been a whole new world for 4 days, I tell you. For
we'll
5 months.
Take it every day, right?
Yeah. Every day is a joy.
That Dr. Schwalb said that if you don't see the compression on the MRI, that he would not do an MVD, because I've always heard that many times it doesn't show up on the MVD until they get inside, including Dr. Piper, Lynn, would always
Yeah.
I'm surprised to hear him say that if he didn't see a compression, he wouldn't do an MVD.
Every neuro, Mary Ellen, has your own way of diagnosing. I think the advantage with Dr. Schwalb, not having heard him for a few years now, he has a very excellent way of making a very severe and complex facial pain condition very understandable. I guess I would refer to Katie, who's new of this, to see if she concurs with that. But some of the neuros can be like they're talking to a group of other neuros, where Schwab was really good at making it very understandable
Yeah.
to even new people that are joining us. I would think, anyway, having had
I agree.
25 years of listening to Neural's talk.
No, I just question that because I've heard so many people, and even on the online support groups, say that
Right.
you know they couldn't see, their doctor couldn't see their compression either until they got inside, and then there it was. You know,
It's just like with stims. If anybody were to ask me about the PNS melody, I would give you people's experience separately that have found them not worthwhile. But again, you don't know until you try it. And as far as going to some company that just started something out in New Jersey, good luck. I gave you a separate email on that, Mel.
Well, yeah, Tim, I was surprised to hear that he didn't consider what we have as TN2.
Yeah, that's another whole ball game.
I was really surprised.
No, he's running with. I didn't want to argue with him any more than I already did. But he's running with. I want to be, I want to be professional with him as much as I can. But he's running with Ken Burchell's out of Oregon Sciences, out in Oregon's vocabulary, and I understand it. But he stood there or sat there and still called it trigeminal differentiating pain and trigeminal something else. But then turns around and says it's not TN2.
Yes, he said it was not TN2.
I know. But those of us that have had shocks like I've had and constant pain, I don't give a shit what he calls it.
Yeah.
It's TN2 to me.
And even
Sorry,
burning,
Maria.
I've had even
more like
burning.
TNS.
Yeah.
And Tim, I've had even burning pain, which fits in with the TN1.
I can't relate to that. Lynn can talk to you about the burning pain because I didn't have that.
And I think that's also from nerve damage. So you don't have any burning. You don't have any burning nerve pain, Tim, in the area.
You know what's burning to me, Lynn, might be something else to Melody. I never felt burning.
Right.
And from the day I started opiates with Dr. Mearshart at Beaumont, God bless him. In fact, next Monday, I'm going to have lunch with the doctor at Emory who diagnosed me
Seriously. Oh my gosh.
Oh, geez.
After having gone to Mayo Clinic and Cleveland Clinic trying for a diagnosis, I finally got one at Emory in Atlanta. Now, people would be interested to know that 2 or 3 years after I saw him, he went to work for Purdue and was right in the middle of the OxyContin issue.
Well, I was just going to say I'd like to be a fly on the wall before you brought that up, but then even more so. But I'll tell you, OxyContin works better than MS Contin
for you
as far as pain control. But
OxyContin does.
I had dealt with thousands of people on the internet when there was a group called ASAP, American Society for Action on Pain. The fellow passed away, and the group's no longer there. In fact, being an executive at GM, I carried a picket sign against the DEA in DC with my daughter back about 20 years ago. But again, don't misunderstand. Those of you with classic, do not ever try opiates. The body needs a constant pain to offset the severe impact of opiates on you if you have intermittent pain. You only do that if you have constant pain.
Tim, I never had the burning pain until just recently. I went to my dentist. That's why I said things took a downhill turn. I went to my dentist because I thought maybe I was having a little bit of a bite. Like maybe my bite was off because I was having a little bit worse TN. And
leave the meeting.
And so anyhow, he did some drilling, like filing, and unfortunately he went up into the TN area, and now I've got burning pain. I never had it before.
Yeah, I keep the recording going, Pete, if you shut it off.
No.
Let it go. Some of this, okay.
No, someone else left, that's all.
Oh, is that it? Sorry.
Melody, there
Yeah.
are doctors at U of M. They call them facial pain doctor. They actually dentists, but they specialize in facial pain. So that area, you don't want to go to dentist for your pain. You want to.
I know I should have never went to him for to have, you know, like thinking my bite was off. I should have never went to my regular dentist.
Melody, I gave you a text. You should see Dr. Munier, the new pain doctor, and see if you're only on Norco. You're not on morphine or what Lynn and I have taken.
That's right.
I told you some time ago, I thought at some point, because TN progresses, TN1, TN2, TN52, all of them tend to progress. So you might need a stronger than Norco.
I didn't know that.
We'll catch up to that, Emmy.
So what's the difference between TN1 and TN2?
One is sharpshooting, like shocks, electrical. That's TN1. That's the classic. And that usually responds well to like Tegretol. That will stop the pain. A lot of people are allergic to it, and that's why they came up with Trileptal, which takes out the allergic agent, and people do well with that. But
both of them.
Lynn, did you have the TN1?
No, mine started out as constant burning. I have had shocks though. So mine is, I would say mine is TN2 and continuing.
It is. Lynn is an RN and is an excellent source for a medication question. Sorry, Lynn.
Thanks. So, Melody, I was going to ask you, have you tried the lidocaine, that oral lidocaine?
Well, you know that, funny you should say that. I was thinking, how can I get it?
From your dentist. Your dentist
My
prescribes
regular dentist?
Yep, your regular dentist.
What do I ask him for? Lidocaine 2% or?
Yep, that's exactly right.
Well, you can get lidocaine 4% over the counter, Melody.
Yeah, but no, no, you're talking about
benzocaine?
No, you're talking about the patch. We're talking about the
I understand. There's a
I need like a gel or a paste or something like that.
It's oral it's lidocaine hydrochloride, oral topical solution, 2% viscose.
I have used the 4% patches though and put them on my face.
And Lynn,
Lynn,
that takes a prescription from my dentist, right?
Yep, that's right. I can send you a picture.
What if he says I can't give that to you?
Oh, he can give it to you. It's just what they use before they give you the shot.
You get neurologist.
Yeah, exactly. Yep. Exactly.
Or my neurologist, or I could ask my neurologist too, right?
The neurologist can't do it. It's only the dentist. I don't know why it is. It's a little quirky. Well, maybe you know, Mary Ellen.
Okay.
You've got a son that's a dentist.
Brother.
A brother, sorry.
He retired about 6 months ago, but yeah, well, and if he says he doesn't have the supply, he'll order some for you, Melody. I don't see why he wouldn't.
Yeah, they get it from you get it from Rite Aid anyway.
Right.
They just call it in.
He may have enough supply.
So he should be okay with that, right? Yeah, because he's the one that did this to me, you know?
Yeah.
Right. Okay, thank you, Lynn. Thank you guys.
Melody, have you told him that?
No, I've got an appointment tomorrow morning.
Oh, good luck.
I
good
told
luck
the
to both of
office.
you.
Yeah.
I know. But you know what? He knows I have the TN. And why he went up there, I don't know. But I mean, it just triggered a whole nother ordeal for me, you know.
And I think with the stress that everybody's under now between COVID and the war and everything, I think we're all grinding our teeth and pulling hair.
Hey, Melody.
Well, it should have taken more off the bottom and not gone.
I got the lidocaine from my neurologist. I just call in and he sent it to my pharmacies and I pick it up there.
Wow.
Well,
that's
okay. Well, if I can't get it one way, I'll get it another.
Pharmacist thing. Okay.
Yeah. Good.
Okay. Well, I have both, so I'll try both.
Yeah,
Thanks,
good.
you guys.
Well, Tim's in Florida. I think that's where our next meeting should be.
Yeah.
Katie has a question.
I wanted to just toss in, I'm so new to this and I'm on a steep learning curve, but if I understand what you're talking about in terms of getting dental work, many of my family and friends who are just learning about this with me are saying, you know, do you grind your teeth? Are you using a tooth
bite guard?
And because I have another friend who has TN2, she said I wouldn't mess with putting anything new in your mouth at night. And so I'm not sure which direction to go.
Why would you say that?
Yeah.
It will relieve some of the stress and pressure on your jaw and the nerves. That doesn't make any sense to me.
Lynn, do you think I should get a bite guard too? That it might help with the pressure of...
Melody, let's finish with Katie first, okay?
Sorry.
Katie, maybe she's thinking that because, you know, depending on everyone's TN triggers are different. Like sometimes mine is when I'm eating, so that's like in my mouth, but sometimes it's just talking or touching my face. So it depends. So maybe she doesn't want you to wake up because your own bite guard that you put in for comfort may cause you some pain. I might just, if you sit at a desk at all during the day or read or something, I might put it in and just test it.
Oh, that's a good idea.
You know, before you have the dentist make you like a really special one. That's going to cost you a lot of money. Because
there are some that are kind of spongier. They're more like silicone squishier. They're not the super hard. I've had a hard one years ago, but as you probably know, the grinding kind of goes in cycles. So when I wasn't using it anymore, I wasn't using it anymore. And then my teeth changed. And so I don't have the one that my dentist made anymore, but she recommended getting the softer. They're almost more like just little pads that have a little squish.
Yeah. They're like silicone, right? They're just
like silicone.
You think you could just, like, if they have all those for the shoe stores that they're doing all over at everybody's corner, we could have like dental pain, like come in and make your own.
So it's like using a mouth guard that is soft is okay. And is the lidocaine question that you're talking about what you do to prepare for having dental work? So before you have any shot?
Yeah.
No, the kind of surface lidocaine, like you can apply where it's the pain, like on your face anywhere. You put it that area numb.
Okay. Yeah, but like, so you can swish it around and then like drool it out. You don't want to spit because could trigger something else. But yeah, that really helps just to numb your teeth enough so that you can brush them, or like if you can't eat, a lot of people have had good luck with just getting it numb enough that they can eat.
Oh, that's so helpful.
And then can you give us the full name of yours again? I was trying to write it down.
Yep, it's lidocaine. I don't know how to do this. It's lidocaine hydrochloride. Oral topical solution. 2% viscose.
Thank you.
VISCOUS.
Thank you.
Lynn was a dental assistant as well. Plus, Lynn, can't you buy a mouth guard right at Rite Aid? I've bought them over the counter before.
Oh, really? Can you? Oh, I would love to try that. I know I'm grinding my teeth, and I think as I'm getting older, they're moving, and it's like, oh no.
I think mine are moving too.
Oh, this is making me crazy. What else I thought gravity just happened to the rest of me. It didn't know it happened.
I was able to find the silicone one on the CVS website, so you might see.
Really?
Yeah.
The silicone's on the CVS?
Yeah, and it doesn't necessarily say silicone on it, but it says soft. Somewhere in the
Okay, soft.
Well, maybe we're learning together. Wouldn't that be nice?
Yeah, and it's not the kind that you bite and boil. It's a no boil thing.
Okay.
I don't want a boil thing. I tried that.
Yeah.
Develop your own mouth. Yeah.
It's called a soft one, right?
Yeah. On the topic of like the mouth guard, I went to a doctor's at U of M, and her background is dental, but also she specialized on facial pain. So they more like a team. I saw that team as neurologists over there working together with facial pain, so they can isolate. If the pain it come from your T grinding or whatever, they can isolate that. And they can determine, is that from your T grinding or is that from your nerve? So they work together.
Right.
So I went to U of M because my son referred me to, my son is oral surgeon. He referred me to.
Oh, nice.
And then I started out with the facial pain doctor. And her background.
Who'd you see, Mr. B?
I can send you, if you give me email, I can send to, I don't remember top of my head.
Okay.
Yeah, send it to Tim and then Tim can send it on to everybody, or maybe in the next newsletter.
Yeah.
Okay.
And then when she isolates, she makes sure that the pain head not coming from your mouth and it come from the nerve somewhere, and she will put in recommendation. This is an area she suspect. And then at that point, you go to neurologist. The neurologist do more analysis.
Nice.
Okay.
Does your son see very many trigeminal neuralgia patients?
Yeah. She the one who point out is my TN, and she sent me to neurologists at U of M, and then they confirmed that. And the professor who trained these residents, and he also confirmed that with me. But in my case, kind of, like somebody asked a question earlier, do you see any dentation on your nerve, right? But in my case, they say the term they use a butt, like next to it. My nerve still not compressed or damped or anything like that. But I went to the brain, and they monitor the signal. It's a change too much, and they slow down. So every surgeon, they do things slightly different. They're not all the same, according to the professor.
Right. Yeah, they have different protocols for whether it's a teaching institution or not, too.
I tell you, when Dr. Brown saw my husband's scar from the first surgery, he goes, "Oh God, he goes, he was not trained the way I was." He goes, I would have like a small incision. My husband's scar is huge. He goes, and I go, "Oh God,"
Yeah.
I know it's
completely different.
Yeah.
It's scary.
So that's why the pre-op, they collect a set of data, and that set of data being used during the surgery. And different doctors use a different data set, to monitor what they're doing. And like Dr. Brown, and then Dr. Schwalb earlier, and he didn't quite get it. He think that, they put a piece of something. No, at Yarmouth, they drill a hole so small that they actually put more like cement to seal that hole up. So it's not like the scar, the piece of bone, after they replace it, they take it out. They don't manipulate it so small because they drill it out and it become like dust. And then you get a hole in there and they seal more like a cement type. It's not like a piece of something they put in, they put like cement. And then they have a layer and they put cement on, they put another layer, and then it become hard. And they say that we hard like rock, that air will never come out. So everybody do a little bit different.
I noticed too on the site, you guys may have seen on the facial pain site, there's a whole article on Teflon-free MVD. That's maybe something we can look at a next meeting, but I'm really curious about what's been written here.
Yeah, that is a great site.
I want to jump in. Teresa's been waiting for a long time. She has a question related to dentistry as well. She's had her hand up for a while.
Sorry, I can't see that.
Teresa, go ahead. You got on mute.
Hi, I just wanted to respond. I had two things. One, I just wanted to respond to Katie. So I wasn't using my bite guard for a while. And then after I had my surgery, I definitely had to go back to using it because I'm numb. I can't tell if I bite stuff in my mouth sometimes. So at nighttime it was problematic. So I use my bite guard at night. My neurologist recommended I go back to it, and I've had no problems with shocks. I did initially, way before surgery, I had to stop using it, and then now it's gotten better. And then I'm also going to be getting Botox put in my jaw because my jaw muscle, the masseter, whatever it's called, is so sore and tight that I have a hard time chewing. And some of the hard time chewing is because for me of my rhizotomy, like I just have a hard time like identifying, I guess, where the food is in my mouth. I don't know. So I'm actually going to have that done as well to kind of relieve like dental, like mouth pain when just I'm, talking.
That makes sense. Chewing. Yeah, that makes sense.
You had the rhizotomy, Teresa?
I did. Yeah, I had a rhizotomy at the end of November in 2021.
Where did you have that?
I had it done at Beaumont, Royal Oak. So I had an MVD on Tuesday, November 23rd, and then I had an MVD recheck in the rhizotomy on Friday, the 26th.
Who did those?
If I could just maybe not share the name of my surgeon at this time.
Yeah, of course.
Only because it didn't like go exactly as planned. I will say I have nothing bad to say about him. He can't control how my body reacted. And that's kind of why I asked Dr. Schwalb, like maybe what did he think? And it was basically kind of what my surgeon had said. I'd been weaned off meds too early. And then my TN was caused by an arachnoid cyst. So they had to drain the cyst. And then I still had a compression. They had to put, the Teflon in, and my doctor's thoughts were like, your nerve just must have been very irritated by this entire thing. So they had to do the rhizotomy because I had all new triggers and it was just miserable.
So you may actually be cured though, right?
I don't know. We'll see. My neurosurgeon's like very optimistic, and my neurologist is more kind of like, wah, like maybe we'll see. He's definitely a little bit more pessimistic.
Caused by a cyst, right?
Yes,
and
not my nerve is misshapen because of the cyst. So we also have to see if it's going to straighten out, and that might be because of the cyst. Like it's not just like a small compression. Like my nerve is actually like totally misshapen, probably from birth. Actually,
did they see the cyst? Did they see the cyst on the MRI?
They did, yeah. That was the reason I had surgery. Is they saw on the MRI the cyst, and they're like, this is very obvious what's happening. Your cyst is compressing this nerve, and there was like a blood vessel, just like the blood vessel and the cyst together were just like putting a lot of pressure on it. Right. So yeah,
other people to fear an MVD for no other reason. That's why I asked. You had a complicated surgery.
I did, yeah. And my surgeon though was after I had my problems. This was over Thanksgiving. He saw me the day after surgery. He came to visit me on Thanksgiving. He was very caring and very responsive, and he was like, I put in like a call to like everybody I know, like every other neurosurgeon who does this surgery, to ask them like, what did they think went wrong? Like, what should we do? He was like looking up research, and he was just really great. So even though it didn't work out the first time, and then the other thing is like, I may have just had to give it time, but he and I were both like, why should you give it time, like, and be in horrible pain while you're waiting? So anyway, I was just going to say, the bite guard for me has been fine, and my neurologist recommended it because for me, a lot of times my TN is triggered when I bite too hard on something, like even like gritting my teeth, like to do something, it will trigger it. So
I don't even want to chew hard foods.
No,
Me either, Lynn. Me either.
I did wonder though, I had a question about dental practice that specialize in facial pain. I'm like terrified to get a cleaning. I don't know how knowledgeable my dentist is about this. So I'm just curious, like in the area, if there's any particular dentist or like practice that people go to or recommend where they've felt like they were really knowledgeable about it and very maybe like gentle with the procedure.
There is a nice write-up on dental care with TN on the facial pain website, and it's about increasing your meds, prior to going. If you're having any type of a flare-up, to cancel your appointment and make it for a better day. And you could have them numb up just the quadrant at a time, just like a fourth of your mouth at a time. especially, and wait until after you get your Botox. You know, those are some ideas that I would suggest.
But you heard even Dr. Malik said, don't go if you don't have to.
Yeah, but you don't want to let stuff build up either.
I know.
I was thinking about pushing it back another few months until
Mary Ellen, we know you're scared of getting that bleeding.
I know. Like when you're doing so well, it's like you
I
know.
I know.
On that facial pain conference in January, the dentist was amazing. His lecture. Tim, I know you were on that conference. I saw your name on the facial pain. He was amazing and gave even some great things to buy. So there's to help with dental health, these gels that more of a fluoride, deeper fluoride gel that you leave on your teeth for about a minute and swish around, and I'm not saying spit out, but the soft brushes. So he was amazing. I thought I got so many tips from him.
Those recordings are probably available. You have his name, Roseanne?
I can check, go through my recordings, and I can email you, Tim.
Yeah, I'd like to have that.
He was amazing. And Katie also, there was a doctor, and I'm not going to remember his name. I'll go through the recordings when over the weekend, who does Teflon free MVDs. I don't remember his name either, but he was speaking, and he was amazing too.
Oh, that one, I heard that Mayo Clinic, one doctor doing some like that. They call them like MDV, but like repositioning of your blood vessel. So actually they move it away from your nerve, but they don't put Teflon in between.
Mm-hmm.
So
it depends on how severe if it's a pretty deep groove, they almost have to, otherwise it will slide back in there and you'll end up with the same problem.
Yeah.
So it depends on how severe it is.
Yeah, that's doctor call, right? They look at, I have a question during our conversation over here. We don't record it, right?
No, it's recorded.
You can shut it off.
Record it because,
Do you want to
thank you.
Shut off for a minute?
Yep.
No, earlier I used some name and I don't think I have a right to use name like that. So.
Well, you want me to go back when we edit it? I'll be editing it. And take it out.
Edit the part that I mentioned about the doctor, names.
You didn't mention any doctor name, did you?
I don't remember you saying any names.
Yeah, I did.
Okay, how far back? Twan, just send me a text on that and I'll have it. How far back was it from here? Like a half hour ago?
Maybe, let's see here. Maybe about half hour ago. Yeah.
I didn't. So maybe for me too, because I mentioned Cornell. I don't think I mentioned the doctor's name. I know I mentioned Cornell though.
Discussed that before, I think, Roseanne. Yeah.
I'll look for it. If you want to send me just a quick text to remind me, that'd be great.
All right, Teresa, did you have anything else you wanted to ask before you leave? I think maybe she had to step out.
No, I was going to say, if you attended the conference in January, all of the all the videos are on. Like I just signed back into the conference and they were all there.
Are they on the FPA website, Maria?
Yeah, I signed in like I was going to go to the conference, and it just says view recording on all of them.
You can see all of them. Yeah.
Right on the facial pain site.
Yeah, I went to the facial pain site and then I went to the January conference.
Okay.
And like I was going to go to the conference, like logging
But you
in.
registered, didn't you?
I did.
And I didn't register because I was having a bad.
I didn't either.
Go around, so I don't know if we'll be able to. But
and I don't know if I can. If what I'm looking at, if I can send it.
Right.
Yeah, they probably.
If you can't pull it up, sign in as Tim Guth. Then you'll get.
There you go, breaking the rules again, Tim. Front and center.
Or
yay, Tim. Yay, Tim.
Send it to you.
Oh, he's a riot. You're a riot.
Yay, Tim.
I have his name. It's dental care for neuropathic pain patient His name is Gary D. Classer, Classer. He's at the Department of Diagnostic Sciences School of Dentistry in Louisiana State University. He was excellent.
Thank you.
So it's Classer, Gary D. Classer. He had such great
ideas,
even just things to buy, like the everyday life, like hearing
That's
all
great.
of all the you
Right.
know, it's so much with that. But now I need to learn how to deal with his daily when he's,
Yeah,
you know,
exactly.
and I'll look up the name of the surgeon who did the Teflon free. That one I have to go through the recordings. Teflon free.
Maybe it's in the article that they showed too, and the.
Let me just check to see if I can get it quick.
I can show you my denture, why I didn't make notes on that one.
You got find
It's shown on here on this article that I picked up off the site.
Right.
Richard Zimmerman from Mayo Clinic in Arizona.
Okay, perfect.
He's writing this.
Richard Zimmerman.
And he's just reporting on what he's seen in his own practice. So he's wondering if others are maybe going to be willing to try it as well.
Yeah. He's a neurosurgeon, Katie.
Yeah.
All right, well, I have to scoot, so.
Okay,
Thanks, guys.
Bye-bye.
All right.
Yeah.
Everybody have a
So
good
much. I
good
really
month.
appreciate
Yeah.
You better check.
You're not alone.
Thank
That's
you.
the best feeling.
You're not alone,
Yeah.
Katie.
We have
Everything
them next month.
has
So
felt so much better in the last 24 hours, just feeling
Oh.
connected to other people. So
I know you really feel so alone, don't you? Like it's so hard. If you ever want to call or, touch base, I'd be happy to chat with you. We've all been there, and it's so scary and it's so isolating.
It is. I mean, you can just sit down and cry, sometimes.
I'm crying right now.
Yeah. Things are gonna get better though. At least we have medications and support. We didn't have all that, years ago, and now we have people that we can call and say, touch base and see what's working for each other. All right, you guys.
Thank you so much.
You're so welcome. Take care, honey.
Bye-bye.
All
Take
right.
care. Bye. Thanks, Lynn, Tim, Pete.
Yeah, thanks, everybody.
Thank you.
Okay. Good night.
Good night, everybody. Good night.
Roseanne.
Night.
Glad
Thanks,
about
everybody.
your husband, Roseanne.
Yeah.
Thank you. 4 days.
Bye.
Yay.
Yeah. Take
Thank
care.
you so much.
You're welcome. Bye.
Bye.
Bye-bye.
Bye, Mary. Hey, you
Bye,
and I
Mary.
started and ended together.
Yeah.
Nice.
I know. It was good. It was good
Especially
listening.
without
Is Mary Ellen still here?
No, she dipped out.
Oh, okay.
Yeah, especially because Pete and I didn't have any internet. Like
Oh my
a
God.
half an hour
that's-
before.
We didn't have internet. I didn't have internet either.
I'm doing it on my cell phone. I've been holding my cell phone for 2.5 hours.
Oh.